modern approach in labor. And I doubt whether I will meet your expectation today, because when you ask for modern approach that obviously always includes new technique, new drugs, new protocols, so I don't want to talk about that. I really want to talk about a modern approach on labor. So I will not talk about breach today, but on that topic. And what we have to realize, if we are really honest, then I have doubts whether we as obstetricians, and I define myself as an obstetrician, whether we are actually doing a good job. If you just look to that graph, I choose Norway. Everyone knows Norway in Europe has an extremely low perinatal morbidity rate, an extremely low maternal mortality rate, an extremely low cesarean section rate. And although, if you just look at that graph here, and you observe just the last 2 decades, then you identify with this line the induction of labor rate. And that induction of labor rate increased from 10% to more than 25% within 2 decades. What is the result of that decision to induce at least a fourth of the whole population? A massive increase in postpartum hemorrhage, a little bit increase in vacuum and forceps. You don't reduce it, you increase that by somewhat like 30%. You have an increase in emergency cesareans. You have an increase in neonatal intensive care unit stays for the newborns. You have no change in elective cesareans. You have no change in APGAR scores. You have no change in fetal death. And you have no change in neonatal death. There is a problem. There is a real problem. What are we doing here? So we are increasing our induction rates from 10 to 25%, and that is a conservative country here when it comes to obstetrics. And we double the cesarean rate, and there is no positive but negative impacts on maternal morbidity. If you look a little bit closer in that paper to the impact of the pregnancy week, when you start induction of labor, then again you see no influence in the APGAR scores, neonatal intensive care unit, fetal death, neonatal death rates, but postpartum hemorrhage. That is F, that is there below on the right side. Realizing that with fantastic evidence-based guidelines, we call them evidence-based guidelines, relying on systematic reviews from all our member societies, having protocols for labor in low-risk patients, then maybe we have to rethink what we are doing. What we are doing actually is we are realizing, as I mentioned, with that approach, we are increasing the postpartum hemorrhage, and we want to avoid that, what you see here on the left side in these pictures. That is on the one side an increase in atonias. It is on the other side a massive increase in placenta accreta syndrome. That is a complete unknown disease. We had the first description of a placenta accreta in 1937. We are responsible for that disease. So we have to ask ourselves, what are we doing here? So the recommendation, for example, to have in a primigravid women who decides never to have a child in the rest of her life, if she knows that well, to offer a cesarean should reflect the problem. To offer a woman in 39 weeks or in the beginning of 40th week in a primi-gravid, low-risk pregnancy, induction of labor, to reduce stillbirth rates should immediately give us an idea how we have to counsel that women right. Do we know whether birth will begin? How long will it take? Whether the mother or the child are ready? Think about NICU and PPH, what I mentioned, and what happens, at least in molecular and cell biology, to recognize pathology. Because we are talking about a physiological situation. Giving birth is physiological. There is no pathology. We need pathology to have an indication to do an intervention. And we are losing our field because women rely on midwives. And it is not the bad women, the midwife, who is opposing us as obstetricians. No, I completely understand women who are completely healthy, no signs of any fetal anomaly, completely healthy pregnancy, and then we start with increasing risks. We are increasing risks in healthy pregnancies. We ask for protocols. We don't recognize the estimated date any longer. We are relying on something what was published 70 years ago, and everyone knows the graph of Friedman published in the American Journal in 1954. And you're still relying on that? Really? Go to the so-called evidence in that paper. You believe that labor usually is 8 hours? Really? Do you think the women you are treating today are the same as 70 years ago in the United States? Is it true? Really? I mean, if you just look to obesity, that is the big theme in our world, actually. Obese women need more induction than underweight women because they quite often don't meet the due date, but they have still a cervical length of 3 centimeters when they are 10 days after the estimated date. Cervical ripening didn't happen. Do we ask that? Or do we just have a protocol to do something when these women arrive in our ward, labor wards? Do we have protocols for that? Or do we have an understanding what's happening in these cases? Why do have these women gestational diabetes or type 1 diabetes, type 2 diabetes? Why do these women don't ripen their cervix until the estimated date? I mean, that is the question. And then we can start with a modern approach in labor. Again, not about breach, but what is the fear of a woman today? That is pain, and that is pelvic floor and perineum damage, and that is prosecution for all of us. So pain, okay. Is labor painful? Oh yeah, that is written in our textbooks, right? That is the first sentence is, it's painful. But what is your experience in your labor wards? There is a group of women, they deliver within 3 or 4 hours, and they don't even ask for pain relief. Not because they don't have time for that, because they don't need it. And others just start with the first contraction, and it is so painful that they definitely need it, although there is no dilation in the cervix. So maybe we should restart again to understand what is physiological and what is pathophysiology. And that is what we have done when we were medical students. So actually, we in obstetrics, unfortunately, we are discussing, and still most of our patients are low-risk patients. We decided to influence, to search indications for interventions in these patients, although we are just in a physiological situation. So, giving birth, when is there pathology is a main question. When is there an indication for an intervention? We should ask ourselves whether we have an indication to do something. What are the consequences of our interventions? You have just seen that with the Norway data from the Norway survey. I have no conflict of interest, but nature and evolution, can we trust them more than our own knowledge, the evidence we ourselves produce? Do we not follow the findings of our studies published in our journals and textbooks and the statistically validated systematic reviews for the safety of our women given birth, also for our own safety? After all, we know how long a birth can last. How long, I mean, Friedman, 70 years ago. How long a pregnancy can last, and which molecules nature has mistakenly not sufficiently provided us within natural processes without pathology. So we have protocols to always, again and again, without any other indication, to give hormones like oxytocin. We have that in our protocols. We do that routinely in low-risk patients without pathology. We add on something, believing that we have an indication. Also, there is no pathology. So we know better because our knowledge has revealed this, right? Or maybe not. Or should we go back to our craft, understand nature when it comes to physiological process, such as birth, and understand where pathology begins, where interventions are indicated. So I really don't want you to leave now labor wards. I want you to rethink what we are doing. We need better trials. We need better research. We have to understand what is happening in physiology. We shouldn't immediately talk about drugs we had to administer to our women without any indication. So when we ask for reasons for cesareans, and here elective cesareans are excluded in that graph, and that is from 2011, published in Obstetrics and Gynecology in the Green Journal. So 1/3 of these emergency cesareans is related to labor arrest. Oh, what is nature doing here? I mean, 1/3 arrest of labor? Do you really think after hundreds of thousands of years evolution, there is 1/3 not a stop of labor? Is that really your belief, or is there a human factor here? From us, a doctor factor, a iatrogenic factor. 17% malpresentation, that is not breech. That malpresentation. How come that in a cephalic presentation, the baby doesn't turn right? Although the pelvis of a woman is perfect for that, because they are lying in beds. Nature didn't recommend beds for giving birth. And you have seen that in the lectures when we talked about breech deliveries, the huge influence of the position of the mother in second stage and labor, and whether they are moving or not. We come back later to the movement in second stage. Non-reassuring fetal tracing. Oh, maybe the CTGs are wrong, because that is not related to anything what you measure later in these fetuses. Yes, sure, we have to detect, and fetal-maternal medicine is doing a great, great job. We have to detect those fetuses which are at risk. Then we have pathology, and then we have indication for interventions. That is fantastic. But not in a healthy baby with a normal perfusion, when everything is fine, everything what we know, everything what we have done is perfect. Then maybe something's wrong with our indication. So first stage, insufficient cervical ripening. Is there anyone in the room who can explain that to me? And how come that more and more women, and I told you, I just gave you the pictures, 2.5-fold higher rates in delivering after the estimated date, worldwide. How come? I mean, one generation, there is no genetic base for that. If a mutation in a population is implemented that needs, geneticists are telling us, 300 generations, not one generation. Women given birth today have the same genetics as their mothers and grandmothers. So what about this cervical ripening thing here? What is influencing the cervical ripening in our women today? Why do we have more and more women giving birth after the estimated date? Premature rupture of membranes at term. What is normal here and what is not? Is that really an indication for antibiotics, for induction of labor? Or could we find out why in a few cases it starts with premature rupture of membranes? Let's discuss that also in that oration, comes later. Hormonal imbalance, oxytocin. I mean, in most of the protocols, we administer oxytocin in first stage. You think that's right? Really? Do you remember the really good studies from physiology? 40 years ago, 30 years ago, 20 years ago, 10 years ago. Well, why do have women two different hormones for labor? Oxytocin and prostaglandins. Let's see. And specific psychological situations, extremely important, and we don't respect that in most of our units. I include myself. Because if you put a woman under stress, she is immediately releasing adrenaline, and that is the best tocolytic agent on earth. If you set a woman in fear with your behavior, with your thinking, with your counseling, with the lights in the room, with the people running in, you make sure that she will have an arrest of labor. And second stage, malpresentation, prolongation, arrest, maternal malposition, also a topic. So let's start with endocrinology. That was, I mean, today we are forgetting that, even in our medical faculties, in all our universities. It's a real problem to teach our colleagues today. I mean, those who are doing reproductive medicine, they are experts in endocrinology. They really know what they are talking about. But all the rest of in our profession, but how do we define our profession if we don't have any idea about endocrinology any longer? And endocrinology is crucial in obstetrics. It's crucial, but people are forgetting that. And you got Nobel Prizes for that. You see here those who received the Nobel Prize for oxytocin, for the detection of oxytocin and for the synthesis of oxytocin, for prostaglandins, and even for steroid hormones. That was Butenandt in the late 30s, who was the first to give us an idea about the structure of these steroids. So it was so important that those who detected these hormones received Nobel Prizes for that. And today we are forgetting that completely. We put it to the protocols, but how that works, why that works, and more important, why doesn't, for example, prostaglandins do their job in first stage in women with gestational diabetes? Maybe that is interesting. How does that start? Everyone knows that. So the fetus is the one in around 35, 36 weeks, giving signals to the mother, and these signals are hormones. And by the way, someone, Bloch, got the Nobel Prize for that. So giving the information that the baby is ready to be delivered in 4 weeks. So it takes 4 weeks for the placenta to produce enough prostaglandin receptors on the cervix. Because women don't have usually these prostaglandins on their cervix. And why do I know that? Because no women on earth who is not pregnant will have a shortening of the cervix in her life or a dilation. Imagine, we, the gynecologists, would detect in every second woman not being pregnant a dilation of the cervix. What a nice information, a new disease. Open cervix, shortened cervix. We don't have that if the woman is not pregnant. But all of us are producing prostaglandins. Prostaglandin E2. Oh, that is a show later, right? With a light. So, yeah, first, the baby gives a signal to the mother that she should produce prostaglandin E2 and prostacyclin and PGF-alpha receptors on her cervix, otherwise there is no ripening. Otherwise, she will not deliver at the estimated date. And if there are no receptors, and at the estimated date the placenta is producing a high amount of prostaglandin to find the receptors to do the job, and there are no receptors, then something very usual is happening. These prostaglandins go to other receptors, and we will see what that means. So yes, we are talking about oxytocin, we are talking about prostaglandins, and for sure we are also talking about steroid hormones. So when do we detect in normal labor, without any help, without any intervention, at the estimated date, when do we detect oxytocin in plasma of the mother? Late in second stage, not early. And we have these graphs since 30 years, but we don't respect that. There is a reason why you, women giving birth, have two different hormones, the one for the first stage and the second for the second stage. And the prostaglandins, you can see that here, prostaglandins in amniotic fluid, that is in human, this is in use. In human beings, you, for the first time, have prostaglandins 2 days before the estimated date. And if you have rupture of membranes and you are ready, then you get contractions. And if you are not ready, if the uterus is not ready, and maybe also the baby is not ready, then you don't usually have contractions. So, and a typical advice from midwives is, if there are no contractions, then you should open the bladder. Well, that is a crazy idea, because if there are no prostaglandins in the amniotic fluid, because she is not ready to give birth, then you just increase complications without any contractions. So we have to understand the physiology, and we don't. What is that? Yeah, you want me to dance, right?
There's a light fluctuation going on in the region, not only in the whole region.
Yeah,
so
yeah. No, I enjoy that.
You can continue.
No problem, Rishi. So first, the first step is we have to detect receptor. Wouldn't it be a nice trial to relate the receptors in the cervix to the readiness of a woman to give birth, and also in the pathological situation of prematurity? Because we have so many patients with prematurity, but they don't deliver their children. So we have again protocols to treat them without good knowledge whether that will proceed to labor, yes or no. And we know the receptors, and we can detect that. And my strong belief is it should start. These prostaglandin receptors are at the membrane of the target cells, and you can easily detect these receptors, and there are a couple of really good studies reflecting on these topics.
Hello.
And I just brought it here. Anyone who is interested in these topics might go deeper down to the physiology of these receptors in the first stage of labor. But we all of us, since we were born, have also prostaglandin E2 receptors on the pain receptors, the nociceptor. You can activate a pain receptor with different molecules. One of these molecules is prostaglandin E2. So if you have all your receptors on your cervix and the placenta releases prostaglandins, and all these prostaglandins, you know, the prostaglandins have a very, very short half-life time, very short. We're talking about seconds. We're not talking about minutes or hours. So when it is released and it is on the prostaglandin receptors at the cervix, you don't have any more prostaglandin E2 for the nociceptors. If you have less receptors on the cervix, all these prostaglandins go to the nociceptors. So now remember what we have. 2 women, both on the estimated date. One woman comes in, both have contractions since, let's say, 1 hour. One of these women she is obviously really breathing. She's not talking to you. She is just handling her contraction, but she's not crying. It is just a strong contraction. She is challenged by that. She really has to breathe, and you can see that. And we all know these situations. We wouldn't ask her for something. We just wait until that contraction is over. And immediately a midwife knows she will deliver within the next 2 hours. You don't have to examine her. You know that. The other women, also 1 hour, since 1 hour, she is crying again and again, all contractions. She can't stand, she can't sit, she can't walk. She is just crying. It's so painful. And the midwife knows she will deliver in 2 days. Not today, not in hours. We know these cases. We know them, but we don't react on that. We still believe in a Friedman curve 70 years ago, telling us that within an amount of hours, something has to happen, otherwise we have to administer a drug. Oxytocin, prostaglandins, whatever you want. Pain relief, whatever. So let's see all these different cases. One preemie comes in the delivery room on a due date with severe pain symptoms and regular contractions for 4 hours. Admission finding, the cervix is soft but 2 centimeters long and 1 centimeter dilated, and the fetal head is above the pelvic inlet. And that takes hours, maybe a day. Another one comes to the delivery unit. She has strong contractions since 1 hour. She is nearly fully dilated, just contractions since 1 hour. She can't, when there is a contraction, her husband has to hold her, or she has to hold herself. And when the contraction is over, she's smiling, saying, okay, that was really strong. And she will deliver immediately. Another first-time mother comes to the delivery room on a due date with severe pain symptoms, with regular contractions, premature rupture of membranes 1 hour ago, and the admission finding is cervical soft, 0.5 centimeter, 3 centimeters dilated. The head is still in the inlet of the pelvis. So she has a lot of prostaglandins in her amniotic fluid, so she is ready to give birth, and that just gave a push. And another one is in 30 weeks, and she has rupture of membranes and not even 1 contraction, because she's not ready. She is not ready. So why we could discuss why she has a rupture of membranes, and it is a little bit too short just always to say there might be an infection. Inflammation, yes, right. So premature rupture of membranes at term might lead to contractions or not. And that is not individualized by the women. It is just relying whether enough prostaglandins were produced by the placenta and the amniotic membranes, because also the amniotic membranes are producing the prostaglandins. And that is a fact. So when there is no contraction, she's not ready. She's not ready. You can start with induction of labor. Have fun for the next week. And all these topics are well described. Let's go back to this 30-year-old graph here. You can find it in textbook, not just only in the paper. And we have to recognize that the first stage is prostaglandin-based, and the second stage is oxytocin-based. And why is it so? I mean, if you have a high blood glucose, we just have one hormone. That is enough for us. If we don't have it, we die. Not today, because we can produce insulin and we can give it to the patient, but before it was detected, before it was synthesized, human beings died. So no replacement for insulin. Here we are in a delivery situation, and you have two hormones. That means you don't have a substitution. It means they have different effects, and we have to recognize it. And when you have too early oxytocin, you know that situation, you know it. Every one of us knows it from the time when we are in labor wards working. The woman comes in and she's 4 centimeters dilated, everything is perfect. And then an hour later, although she didn't need any pain relief, now she starts crying, and the head is pushing on the cervix, and the cervix is still 4 or 5 centimeters dilated. And nothing's happening anymore. She stays with 4 or 5 centimeters, and it is not soft any longer, but there is an edema on the cervix, and it becomes stronger, harder. You can feel that. If you are not very experienced, you might say, okay, let's give oxytocin, then maybe she will deliver faster. She won't. What is the midwife advice? Put her to a bath, to warm water. Why? Because warm water is reducing oxytocin release. So the oxytocin pushed too early the head on the just 4 centimeters dilated cervix. It's wrong to administer the wrong hormone in that situation. And the description, when you detect which hormone in labor, is also, that is more than 40 years old. A fantastic paper, and I brought it here. And they are saying there was a significant increase in plasma oxytocin levels from the time of initial visualization of the fetal head to the time of delivery of the head. These data support the view that maternal plasma oxytocin levels remain low during pregnancy until late in the second stage of labor. We produce problems in labor. We don't have the solution. You know the Ferguson reflex. Yeah, but the Ferguson reflex doesn't mean that you put pressure on a cervix what is 3 centimeters dilated. The Ferguson reflex reflects a situation in which a woman is fully dilated and the head pushes against the vaginal wall. We have to rethink what we learned when we were medical students. Oh, let's go a little bit deeper to research. Patients with poorly controlled diabetogenic metabolism have significantly less favorable cervical findings at the estimated date than patients without metabolic disorders. Well known. And that is our experience every day. Patients with poorly controlled diabetogenic metabolism have a significantly higher rate of secondary cesarean sections than patients without metabolic disorders. Patients with poorly controlled diabetogenic metabolism have a significantly higher need for epidural anesthesia than patients without metabolic disorders. Patients with obesity have significantly less favorable cervical findings at the estimated date than patients with normal or underweight. A significantly higher secondary cesarean rate and a significantly higher need for epidural anesthesia for vaginal birth. We all know that. So why don't we do research on that? Here we are now in a pathophysiological situation. We have an underlying disease. Well, what is the problem? What is the problem here? Is it the pancreas? Is it insulin? Or is it the blood glucose level? We should find that out. Patients with regular physiological activity have significantly more favorable cervical findings at the estimated date than patients without regular physiological activity, and a significantly lower need for epidural anesthesia during vaginal birth. Wow. I mean, now it comes to behavior before labor. Everything's published. And there is a one, I love that publication. Unfortunately, a little bit forgotten. That was done by an Australian colleague from physiology, by Foden. And that paper, again, is around 40 years old. And what he found out is that related to blood glucose levels and related to nutrition, you have different amounts of prostaglandin production by the placenta. So now we come back to our population we are treating today, because we have very different nutrition, not just only obesity rate, compared to our parents and grandparents. High blood glucose levels are usual finding. And you can do that. Today we have these patches, you can measure it on your mobile, you can see how you react on different nutrition. And we use it, we like it. All in my unit, all my midwives, all my doctors, all my colleagues, all my nurses tried that out to find out how they react on that. We have to realize that nutrition today is not as healthy as it should be. And it has a direct impact on the prostaglandin production after 36 weeks. So let us think about trials and how we can produce evidence, what we put to systematic reviews when we are discussing our interventions with good indications. So in use, fasting increases uterine contractility and leads to early birth of viable lambs in animals close to term. We have to realize that. And we don't. We still believe that we have to treat the patients related to the evidence we produced in our trials 50, 60, 70 years ago. There are fantastic reviews and systematic reviews also on the impact of second stage and the maternal position. And to make long things short, lying on the back is the worst decision you can make for the women. Because usually a woman feels better when she's walking around. Do we trust in nature or do we trust in our advice? I mean, I learned it when I was a medical student and when I was a young trainee, all the women were lying on the back and we were trained to do episiotomies in all these patients because we believed that the Lord forgot to do an episiotomy in labor. We really believed that. Today, the episiotomy rate in my unit is below 1.2%. And we have the lowest laceration rate in whole Germany. But not just only because we don't do episiotomies. We also don't let them deliver lying on the back. And you know that from the talks about breech deliveries. And we have evidence on that. I really don't understand why we don't react on that. That is a fantastic systematic review. You see, Gupta was responsible for that, delivered in the Cochrane database. That is a fantastic systematic review. The evidence was quite low, but that is the problem of the trials. That is how they included the patients. So maybe you restart it again in your beautiful country to promote trials, randomized trials on this topic. And what you will see is faster second stage, less lacerations, better outcome of the babies, and better outcome of the mothers. And everything is written here. So we just have to reproduce and do better trials on these topics. So the author's conclusion in that systematic review in the Cochrane library on the position of the mother in second stage is, if she is in upright position, the result of this review suggests several potential benefits for upright posture in women without epidural anesthesia, such as reduction in the duration of second stage and reduction of perineal incision rates and assisted birth. Here they mention without anesthesia. Well, I mean, these trials were quite old. Today, the gold standard is that women with epidurals are mobilized. There is no reason that they shouldn't walk around, that they shouldn't have a walking epidural. And that is not another technique. That is just another concentration of the same drugs. So you can immediately implement it. We are struggling with that in Germany. I even don't understand why. Because there is no change for the anesthesiologist or for the obstetrician in that procedure. It is just different concentration of the drugs. We are very much interested in the impact of the position of the mother giving birth, at least in second stage. And that's why we use open MRIs actually with our pregnant women. And we try to find out, why is the pelvis of a mother mobile and what is changing in different positions. And what you immediately detect is that the angles are completely different in the pelvis, and also the wideness of the pelvis in the inlet and the outlet of the pelvis, if they are in upright position or if they are lying on a back or on the side. So there is an impact of your counseling, how she should deliver. And we should produce the evidence. As long as we don't do that, we won't have it in systematic reviews. As long as we don't have it in systematic reviews, we don't have it in our guidelines. But that doesn't mean that we follow the right evidence. So I know that I didn't meet your expectation on modern approach in labor, but I strongly believe that after this talk, you might reflect what you see in your labor wards and how we can improve labor in future to make sure that women, again, rely on us as obstetricians when it just comes in a healthy woman to labor. So thank you so much for attending this session.
I think this talk, which was very eloquent and elaborate, has completely turned our heads around what we should be rethinking about. In fact, after the COVID era, the words such as rethink, reform, restructure, research, all of these have become very, very popular. And this is yet again another topic which inspires us to do the same, because we have been oftentimes blamed for over medicalization and also not adhering to the standard protocols. Perhaps by intuitive decisions, sometimes we differ or delay, and many a times iatrogenic premature labors, also the clinicians are to blame for their decision making. So this is a whole big Pandora's box of rethink, with Frank Louwen as our future leader of FIGO. I'm sure not only on this topic, but on many other existing practices, we will produce more evidences in keeping with the present era, and we move forward on a new path altogether.